studies and some OSCE style management stuff. So we'll go into the first case. Okay, apparently some people are having problems with...
Yeah, I'll sort it. You continue.
It's just loading for me as well, so...
Oh, fair. Also, this is being recorded for people who can't make it.
All right.
I'll post the slides in the chat as well. If it's not working for you, you can follow along because I'll just put the slides in the chat. Arnav, I'm still in control. That's why it's not loading for you.
Yeah, it's just loading. I don't know.
If you have slow internet, this is probably the problem. Do you want me to just do it? I can do that.
Yeah, it was quicker that way.
Yeah, it will be. Let me just... Right, fine. Can you see that enough?
Yeah, cool.
Fine.
Yeah, next one. Cool, so let's start with our first case. I'm just going to read this out. Mr. Krev, 67, presents to A&E with really bad abdominal pain. His past medical history is of osteoarthritis and a previous MI. He takes GI antiplatelet therapy and a statin for secondary prevention. When you start to examine him, he starts to vomit blood. The nurse is in the process of taking observations. What do you do next? Any ideas? Yeah, you've all been students for 4 years. Yeah, next one. Cool. So a lot of you already know the answer before I put it there, which is great because this will be like one of your questions probably in the SBA. So it's a free mark. In reality, yeah, just go on to the next one. It's quite easy. In reality, you would do almost all of these things apart from maybe giving blood because that depends on your hemoglobin concentration. So you wouldn't give that immediately necessarily, but you do all of the others. Yeah, next one. Cool. So A to E, you've probably started practicing the OSCEs, but I'm just going to go through it again just to make sure everyone's on the same page. It will probably be 1 or maybe 2 of your OSCEs in 4th year, will be in 5th and 6th year as well. And it's good to have a structure, so we'll go through that. Yeah. Cool. So Mr. Krev, he's vomiting blood, but he's able to complete full sentences. He's not aspirating. You don't hear anything else. You look at his hand and look a bit blue, a bit pale. Everything else is normal in his chest. He looks pale peripherally. He's got cold peripheries, reduced turgor, so it seems like he's a bit dehydrated. Everything else is pretty much normal apart from his observations. So which of these things are you worried about? Just type in the chat. Yeah, saturations, I'd be worried. Yeah. Anything else? Yeah, low blood pressure, you're worried. Exactly. So those are the main things that you're worried about. Next one. Anish.
Sorry.
Yeah, so I've just highlighted them. So those are sort of your positive findings. And that's what you should keep in the back of your mind. Let's say you were doing an OSCE scenario to report back in your S-bar at the end of the station. So Mr. Karev, I've clocked him in, his airway was patent, he was peripherally cyanosed, cold, clammy, his cap refill was increased, and then all of these observations. These are important things to say when you're reporting back to someone else. Yeah, next one. And then I've included some things that you should do in your OSCE style scenario. So in your breathing, almost always, I'd personally do a VBG at least, if not an ABG, and then a chest x-ray. In this case, why are we doing a chest x-ray? Does anyone know? Because he's come in with abdominal pain. Like, what's the point of doing a chest x-ray? Yeah. Yeah, so all good ideas, but we're worried about pneumoperitoneum. Okay. And then moving on, I want you to inscribe, no, wait, keep it on the same side, sorry. Keep it, this in your mind. Insert 2 wide bore cannula into both antecubital fossa. It's just a phrase you say in your OSCEs. And you do it in almost every patient, and especially in this person who's shocked, systolic below 90, you'd be really worried. So that's the most important thing to do after your sort of initial ABC assessment. And why do we want to do an ECG? Yeah, referred pain. So he's got a previous history of an MI, and he's coming with upper abdominal pain, and that can still be an MI. So you should always rule that out. And it's important to rule out in sort of upper GI cases. All right, we can move on to the next one. Okay, I'm going to go on a few tangents just because it's important to go through the physiology of this. All right, next one. I will go over pneumoperitoneum in a bit. So oxygen, why is a saturation of 91% important? Because if you convert it into partial pressure of oxygen, it's actually really low. And you might have remembered this in like first or second year. I don't know when you do this now, but it is still important, and it's always good to go back to the basics. So anywhere below like 95% saturations on your SATS monitor, actually after that, if it goes down, it's quite a steep drop, and you need to be worried about that. Yeah, next one. So I've included some general rules for SBAs and OSCEs. Below 94%, just give everyone oxygen, and just be wary of COPD because you want them between 88 and 92%. So any COPD patient, you don't want to over-oxygenate them. Over-oxygenation generally causes harm. So if this patient had SATs of like 96%, there's no point giving them oxygen right now because it's been proven to cause harm. And for OSCEs, there's no harm in starting high flow oxygen initially if someone's hypoxic, and you can always lower it later to like nasal cannula at like 2 liters or something.
Next.
Yeah. Next one.
Yeah, I'm just waiting for it.
Okay.
There we go.
Cool. So we said this patient had a low blood pressure, and that's essentially he's in shock. So it's good to just quickly go over the types of shock. Does anyone want to type out like different types of shock? There's a total of 4.
I went over this with some people last week, so I expect you to answer.
What did you say?
I went over this with some people last week.
Oh, okay, fine. So you should know
so they should know that. Some of them should.
Yeah, so septic is a type of distributive shock. We're missing 1. Neurogenic and anaphylactic are also distributive shocks. All right, next slide. So there's 4 types of shock. The ones we missed out were obstructive. So hypovolemic and cardiogenic, distributive, obstructive, and they all present differently. I'm not going to go over exactly the specifics like clinical findings and stuff, but a good way to differentiate between a quick way to differentiate between distributive and the rest of them is just checking the peripheral perfusion. So if they're cold and they're clammy, that means their vascular resistance is still working, which means that they're still constricting those arterioles and there's no leak. If they're in warm shock, so they've got low blood pressure, but their peripheries are warm, that's more likely to be distributive because the peripheral arteries aren't constricting. So that's a quick way of telling clinically. And you've been over these last week, so I won't go over it again.
Next one. Not all of them have. So
which one have you been over?
As in, not everyone on this call I went over with last week.
Okay, fine. So I'll quickly go over them. So hypovolemic. So if you're bleeding out, that means your stroke volume is going to be low, and that means your heart's not going to pump as effectively. Cardiogenic shock, so in MI, your heart muscle isn't working, so it's not pumping out properly. Distributive is essentially your blood vessels aren't responding to shock, so they're not constricting, or they're overly sort of leaky. So, for example, in sepsis, they're leaky. Anaphylaxis, they're dilated and leaky, etc. And then obstructive is when something large is essentially obstructing one of your larger blood vessels. So for example, in a large pulmonary embolus, your right side of your heart can't pump out any further into the lungs because there's a huge clot that's stopping it from moving. Cool. Quickly in shock. I know this is a bit tedious, but again, I think it is important to know just for the rest of your medical career. So arterial pressure is made up of your cardiac output and your systemic vascular resistance, and your cardiac output splits into your stroke volume and heart rate. So it's really simple stuff going back to basics, but it impacts on how you practice, you know, someone who's hypovolemic. Yeah. So there's two ways your body sort of responds to this: either change the cardiac output or change the resistance. And like I said before, cold shock, it means your arteries are responding as you would expect them to try and increase the blood going back to your heart, and so it can pump harder and faster and have a bigger stroke volume. If it's warm, then you're worried about distributive shock. So this is a huge sort of formula. No one cares. It's, you know, it's really complicated. You don't want to do maths or do medicine, but I'm just going to simplify and tell you why it's important. Yeah, go on the next one. So oxygen delivery, you just split into this sort of formula. And the point is that if you try and increase, let's say, your oxygen saturations, it's going to have a minimal effect on your overall oxygen delivery. But if you increase something like your stroke volume, for example, then that's going to have a much bigger impact. So in someone who's got low sats, who's hypoxemic, you think they're hypoxic, then the best thing you can do is give them fluids, because it's going to improve their oxygen delivery the most out of anything, the most quickly. Yeah. So if you, let's say, increase someone's volume, gave them IV fluids of 1 litre, that's a 25% increase in your oxygen delivery in about half an hour, 15 minutes, depending on how much you give them. And ultimately, packed red blood cells are the best thing to give because they increase your volume, they increase your hemoglobin, but they are stored in a refrigerator, so they take time to thaw out, and then you can give them eventually. But fluids are the most important thing. Cool, so we're back to our patient, Mr. Krev. Anyone want to tell me what the most important finding is here? Yep, air under the diaphragm. And that's why we did the chest x-ray. It's pneumoperitoneum. What that means is air in the peritoneum. So anywhere below the diaphragm, there shouldn't be air unless it's inside the bowel. If you see air outside of the bowel wall or anywhere else below the diaphragm, that means that there's some sort of perforation. Something is causing an air leak in the bowel, and that is bad. All right, next one. Yeah, so I've highlighted a bit further there. Okay, so we did whole A, B, C, D, E, but we didn't really talk about E. Hold on, don't move on, Anush. What else would you do in this patient? Yeah, you want to check the urine output?
Someone has a question about the clavicle.
Wait, go back to it. Yeah, so you want to expose them. So his clavicles look like that because it's an erect chest x-ray, so you have to do this position to get into them, which means your clavicles are in a more sort of steep position. BM, yeah, that's part of your D. So part of your D is AVPU, check the pupils, and then blood glucose. So E, you want to expose them as much as you can. Abdo exam, perfect. So if you're suspecting someone's peritonitic, they will be lying absolutely still, because any sort of irritation or any sort of perforation means that they're in a lot of pain, so they'll stay completely still in the bed, actually, which is a really good sign of perforation. Cool, next one. You should also do a PR exam in someone who you suspect having an upper GI bleed, just because it can confirm the finding of melena, which is black tar-like stool. Cool, next question.
Oh, it is. Sorry, it was the lag.
That's all right. I don't know how many of you saw that. Any thoughts? Anyone? Yeah. Good. Yeah. So it's a perforated duodenal ulcer. So putting all this together, first of all, what factors can contribute from your findings, from the history, from your examination, that this is a perforated duodenal ulcer? Yeah, I'll get into why it's perforated and not bleeding in a sec. Okay, so from our history, we know he's got some sort of, he's not really got, we don't know that he's got established peptic ulcer disease in the past, but the most important thing is in the chest x-ray, there's air under the diaphragm. And out of all of these answers, only one of them would cause air under the diaphragm, which is why it's a perforated duodenal ulcer. It could have started off as a bleeding duodenal ulcer, which predisposed him to a perforation. And we'll get into some of the other things in a bit. I'll go into Mallory Weiss tear. So that is a tear of your esophagus, but it's not a full thickness tear. So it's only a partial tear, and that's from forceful vomiting usually. I've spoken about bleeding duodenal ulcers. Adenocarcinoma, yes, if you have a cancer in your anywhere in your gastrointestinal tract, it can cause bleeding, but it wouldn't present like this. It would be more of a insidious sort of thing. And even then, usually a lot of adenocarcinomas in the upper GI tract tend to cause other symptoms before they start to bleed, such as dysphagia, and a few other symptoms. Bleeding varices is important to think of, especially in patients with history of alcoholic liver disease or general chronic liver disease, and we'll go into that in a second as well. Okay.
You're on that slide.
The next one. Cause of upper GI bleed. So I've included the common ones here first. So peptic ulcer disease, gastroduodenal erosions, esophagitis. So that's mostly caused by infections or medication. Mallory Weiss tear, like I've mentioned, from forceful vomiting, and varices from chronic liver disease. Just a bit of anatomy, it could come up. Upper GI bleeds are classified as any bleed occurring from above the ligament of Treats, which I've put in the diagram there, and that's sort of after the second part of your duodenum. So that's good to know. So erosions and esophagitis, they're quite similar, but esophagitis is in the name. It says inflammation of the esophagus. So it wouldn't necessarily be an erosion such as an ulcer or a break in the wall. It could just be bleeding because of the inflammation rather than an ulcer. Gastroduodenal erosions, it's a bit difficult to explain right now because I'm not too sure what they are either, but they can happen in people who take medication and people who've had endoscopies, and that can cause erosions as well. It's not a huge difference, but you can look it up in your own time. I'm not too sure about that one. And in reality, epistaxis is actually the most common cause, so that's bleeding from your nose. A lot of people bleed from the nose, but instead of holding it forward, which you should do, they hold the head backwards, swallow the blood, and then cough it back up. The Rockall score is just a predictor for adverse outcomes if someone's bleeding. I'm not going to go through it now, but it is testable. It has been tested, so learn it the day before your exams.
What's the other score as well? There's the one after endoscopy.
There's a Glasgow Blachford score as well, but I don't think that it's one or the other, really.
Yeah, I just know that like one of them's before endoscopy, the other one's after endoscopy.
Cool. In Mr. Karev's case, what's the most likely cause of his ulcer? I think it's called the Glasgow Blachford score.
Yeah, Blachford.
Any thoughts? Take a guess.
Do they want the history again?
It'll probably be too much to go back to the history again. H. pylori would be the right answer if I just asked you generally what's the most common cause. But in this case, the answer is medication. So as it says in the history, he's got previous MI, he's on regular dual antiplatelet therapy, and that means he's on aspirin. But we didn't say that he was on any sort of gastric protection, such as a PPI, proton pump inhibitor, to stop the erosions. And so in his case, the most likely cause would be medication. Close second is H. pylori, and then idiopathic isn't really a thing. Stress and Zollner-Elton syndrome I'll go through in a second. Okay, so cause of peptic ulcer disease, H. pylori is by far the most common, unless someone's on steroids, in which case it's probably more contributory, especially NSAIDs or steroids and long-term medication such as this, without proton pump inhibitors, which stop acid secretion. If we used to give ranitidine, but that's been stopped recently. Again, for you could either give a PPI or ranitidine for peptic ulcer disease or for gastric protection, but ranitidine's been stopped now because there's a huge cancer risk. So the only medication we use now are PPIs, and they have their own side effects, which you should read up on. Stress, by stress, I mean not like, oh, I'm stressed for exams, but physiological stress. So an ITU patient who's incredibly unwell can develop gastric ulcers and duodenal ulcers. And there are different types of ulcers, Cushing's and curling ulcers. Burns patients suffer from, I think, curling ulcers, which is essentially a stress response from the body as well. Now, Zollner-Elton syndrome, you probably won't see it in real life, but it's a gastronoma, which means it secretes gastrin, which causes your stomach to secrete more acid. The more acid your stomach secretes, the more likely you are to form ulcers. There are other causes such as ischemia, infection, inflammatory disease like Crohn's, but they are more rare causes. Okay, in this case, we found out that he's got pneumoperitoneum, he's really unwell, he's sick. What do we do with him now? Yeah, you're all getting there. Yeah, so it's E, call the surgical team for an urgent laparotomy. Now, normally for upper GI bleeding, the sort of course of management after you've done your A2E, you send them for an urgent endoscopy to find whatever's bleeding, and you either solve it by banding if it's varices or embolization if it's ulcers, and different techniques. In this case, though, he's shocked. There's pneumoperitoneum. Anytime you have a pneumoperitoneum, you have to do a laparotomy, which means midline, scar in the midline, open them up, not with endoscopes, but literally open them up on the table straight away to find the source of perforation and close it up, because these patients can get unwell very quickly. Flexisigmoid you wouldn't really do to exclude in this situation because it's not relevant at all. We don't think he has a low GI bleed, and even then you wouldn't really do a flexisigmoidoscopy if you thought someone had a low GI bleed. You would administer regular fluids, but that's not the best answer in this case, as CT scan doesn't necessarily add anything at the minute. Yeah. Next one. So just generally things to do in upper GI bleeds, as F1s and OSCEs, whatever. Protect the airway, always the first port of call. So if someone's vomiting blood and let's say their airway is not protected, that you think that they're choking on blood or anything else, they're aspirating, then call the anaesthetist, call someone for help. And then you can do your airway maneuvers, which you'll all learn, I think, later in the year, maybe during anesthetics. Oxygen is always IV access fluids, bloods, correct clotting abnormalities if there's a reason they're bleeding so easily, such as low platelet count, whether they're in DIC, you may have heard of that. Catheterize and monitor their urine output. This is really important because it gives us an idea of how their kidneys are doing. Arrange urgent endoscopy, and then only if they're perforated for whatever reason, then do a laparotomy.
Does someone want to tell us what DIC is, in case some people don't know what it is? Just post in the chat if you know what it is.
You guys did hemolytic anemia, right?
Not everyone here, though.
Okay.
Yeah, so it's disseminated intravascular coagulation, which means you're going to get like clotting in random places in your bloodstream within your vessels. You can get it like if you're just severely unwell with any kind of condition. Yeah.
Cool. We can do DIC at a separate time in a bit more detail. Yeah. Okay. So that was a quick upper GI bleeding case, what to do. So just remember A2E assessment, fluids, bloods, and then management-wise, send them for endoscopy. I've included 3 cases now, which are a bit sort of, you may not see them in real life, but they can definitely come up in your exams. So we'll go through them. It's a spot diagnosis. So all of these patients have presented with upper GI bleeds.
So yeah, right is ascites.
Yeah. So the right is ascites, the eye is scleral icterus and general jaundice, and that's spider nevus. And all of that indicates decompensated liver disease, which means this person's bleeding from varices. Awesome.
Yeah. What's the cutoff for the number of spider nevi you're allowed? Because it can be normal.
Yeah.
Yeah.
Fantastic. Bit on variceal bleeding. It's quite an important topic. So it's increased pressure in your portal venous system. What that means is the red bit that's in the diagram, there's essentially increased pressure, so your veins dilate because there's more blood there. Generally due to cirrhotic liver, because of back pressure, the blood goes to other veins. You should know how to manage this. So in the acute setting, you give them IV terlipressin, which essentially vasoconstricts all of these dilated vessels. Broad spectrum antibiotics, because you're going to send them for endoscopy and they need that as sort of a thing before to give prophylactically before the endoscopy. And then endoscopic banding is first line management for bleeding varices. Sclerotherapy is also used, but banding is generally preferred now. If someone's had a variceal bleed or someone's a high risk for one, you give them propranolol, which is a beta blocker to prevent the bleeds. And for resistant varices that they won't stop bleeding, you do a TIPS. Anyone know what TIPS is? Yeah, transjugular intrahepatic shunt. So you go through a jugular vein and essentially put a hole between your systemic and portal venous circulation to help with the pressure. Because essentially your liver's stopping the flow of blood normally, and which causes back pressure. You're just making a big tube in between, joining the hepatic and portal veins, so that relieves the pressure from your portal system. It's very straightforward. Next one. All right, next case. Here we go.
This one's rogue.
This one's quite hard.
Oh, smash it.
Yeah, awesome. Hereditary hemorrhagic telangiectasia. So what this is it's essentially a genetic condition which predisposes you to AVMs, arteriovenous malformations, and this can happen in any part of your body. Most commonly, they present on the skin or on the nose, which means they present with a lot of nosebleeds. Actually, is most common first presentation, but they can happen anywhere. So in your lungs, liver, brain, and this can cause all sorts of problems depending on where they are. But it's a very classical SBA question, and it can, like I said, it can happen anywhere. So in your GI tract, it can cause hematemesis.
Someone said DIC. DIC could cause this. You'd be given a bit of a history. So, like, yeah, it's kind of unfair that we just gave you images, but yeah.
Last case. I don't know if you're able to see it as clearly on the PowerPoint.
The name a pun?
No. I guess it could be. I mean, they're all characters from Grey's Anatomy, if anyone's ever seen it. Yeah, so the picture on the right shows surgical emphysema. Putting that together, you know this patient's coming with upper GI bleeding.
Yeah. This
Yeah.
one's got it.
So this is Boerhaave syndrome. Again, unlikely for you to see it in real life, but comes up in exams quite commonly. So it's a full thickness rupture of your esophageal wall because of forceful vomiting. So think of it like a more severe Mallory Weiss tear, essentially. So it's gone through completely through the wall. So that causes a pneumomediastinum, excuse the spelling. I'll show you that. I'll go back to the slide in a second. And subcutaneous emphysema, which means air under the skin. Just go back to the previous slide, Anish. So on the left, if you can see the arrows, there's air wherever the arrow is pointing. So between the lining of the heart and the pericardium, between the aortic wall and the pleura there, and mediastinally the pleura between the lungs and the mediastinum, you can see air everywhere, which should not be there. And that means that somewhere, again, air is leaking from your upper GI system into these spaces, and that can happen because of Boerhaave syndrome, but it could be because of, let's say, you've had surgery somewhere in your thorax. That can cause it. And the one on the right is called subcutaneous emphysema. If you look really carefully, you can see the pectoral muscles. You can see the actual musculature quite well because the air's gone in front of the muscles, and that's coming out on the X-ray.
Can you see my mouth?
Yeah. Cool. So again, that's another cause, and they could show you a chest X-ray like that and be like, okay, what's the most common cause? And this is, again, it's almost always fatal unless they have a surgery ASAP. And that's all of the cases that I've gone through. Any questions from anything I've said? Upper GI bleeding is quite a big topic, so I've gone through the more important stuff and a bit of the physiology, and I think it's more likely to come up as a OSCE rather than on the SBA, but I've included some cases.
I've got like a recipe case for you guys as well before you head off. But yeah, if you've got any GI questions, we can go through those now.
Or if you can't think of one now, just post it on this and I'll try and get back to you.
Yeah, we'll get around to it.
Do you going to see us?
Yeah. Why do you get? Oh, so someone messaged me privately. Why do you get subcutaneous emphysema in Boerhaave syndrome and esophageal rupture?
Why?
Yeah.
Because it depends on where the rupture is essentially, but if you've gone through the full thickness, that means the air can now penetrate just before the pleura in your thorax, so your lung pleura and things like that. So if it's upper airway that it's perforated, then it can actually go into the muscles.
Right. So here is something significantly more straightforward than upper GI bleeds. So there's a 35-year-old man presenting with 1 week history of fevers and persistent cough. Actually, you know what? Let's change that to a 1 month history to make it a bit more barn door obvious. So what kind of other questions do you want to be asking? Don't give me a diagnosis, James. What other question? Yeah, travel history is very important. What else? Is it productive? Yeah. What kind of? Yeah, and what color is it? Vaccination history might be good to know as well. Is he immunocompromised? Yep. And hemolysis. Yeah, these are all like really important things for you to ask about. And don't forget, like I know, like as soon as you guys see persistent cough, persistent fever, you're thinking tuberculosis. So you can ask the associated symptoms of that as well. Smoking history is also important that you're now saying now that I put it on the slides, but we won't talk about that. Here are the answers to your questions that you so kindly asked him. He's got 30-pack-year smoking history. Man's name is Mr. Razak from Bangladesh, recent travel to visit family there. Bloody cough for 1 month. Lives on his own. Weight loss of around 10 kilograms over the last 2 weeks, which is crazy. And he's got no other past medical history. Yes, yes. My next question is what your differentials are. Tuberculosis is obviously your top differential, but with a 30-pack year history, you do not want to rule out lung cancer. It could even be COVID given recent events. I mean, I'd hope that they didn't have a productive bloody cough if they had COVID, to be honest. But yeah, TB and cancer, your top two differentials. But like he's got like travel history as well. If it's like recent, you also want to rule out a pulmonary embolus because that can cause like hemoptysis if you get pulmonary hemorrhage from it. So don't forget about that. Because out of these three things, the thing that will kill you the quickest is a pulmonary embolus. But yeah, with the 1 month history, it makes it significantly less likely. Fine. And here's like a good mnemonic for you to remember the causes of hemoptysis, most of which aren't that useful to know. The important ones are tuberculosis, tumors, especially lung cancers, but it can also be caused by autoimmune disorders. Can anyone give me any autoimmune conditions that cause hemoptysis? How does mitral stenosis give hemoptysis? I think it's due to like the backflow of blood and increase in pulmonary pressure. I'm not really sure. Arnaud, do you know?
Hemoptysis and mitral stenosis. I think it's something to do with left atrial dilation.
Yeah, there's basically backflow pressure. Yeah, good pastures, which is also known as anti-GBM disease. What is good? What does that consist of? Like, what's happening? What can you tell me about that disease? Yeah, so they get like a nephrotic syndrome and hemoptysis. They get antibodies against collagen 4. Yeah, exactly. And the two places you have like basement membranes that are going to be exposed to this are in your kidney and in your lungs. Perfect. Any other things that can cause autoimmune conditions that can cause hemoptysis? I mean, for those of you who came to the room lecture, there's like one kind of rare but important one that they like to ask about. It's another vasculitis. Yeah, Wegener's granulomatosis is like a cause of pulmonary hemorrhage. Church-Strauss can do it as well, but it's like a bit less common. But yeah, cool. And then these are like the kind of investigations you would probably order. Get that sputum sample, and you're going to do an AFB stain. What does that mean? And what stain are you using? Yeah, acid-fast bacilli. What's the stain called? Yeah, Zeal-Nielsen. It's the quickest way of testing for tuberculosis, and you can also do a culture at 8 weeks, which is still the best thing you can do, but 8 weeks is a long time. Yeah, you can use Auramine as well, but no Zeal-Nielsen for your exams. There is one other investigation that will give you whether this TB is resistant to any antibiotics. Does anyone know what that is? It's in the. I'll put it in the presentation later. Yeah, you basically do like an antigen test. I think it's NAAT or something, but that gives you resistance as well. But so it's really useful, and we'll talk about that, why that is in a minute. Yeah, check their full blood count, check their imaging. Yeah, it is. It's literally just PCR for the antigen like genes. Right. What is this? This is not miliary TB. Think a bit simpler. I'll show you what miliary TB looks like in a minute. Pneumothorax. If you're referring to like this line here, it's just the scapula. It's fine. This is just like normal tuberculosis, if there's such a thing. So non-complicated, non-disseminated pulmonary tuberculosis. It basically looks like consolidation in the upper lobes, because yeah, exactly. So tuberculosis prefers the upper lobes. So if you see what you think looks like a pneumonia, but it's the upper lobe only, you should always consider tuberculosis. Gone complex. I'm not sure whether I can see any. Oh no, can you see any gone complexes?
Maybe on the left side.
Yeah, maybe one of these might be a GON complex. So yeah. It tends to be in the middle lobes though. Can someone explain what a GON complex is? Does anyone know what a GON complex is? Yeah, it's an inactive granuloma, and it's usually calcified. And I think a complex, you have both like the original granuloma and you have a lymph node that's been calcified. Yeah, so like I think the word complex actually refers to having both granulomas within the lung tissue itself and a lymph node. I'll check on that for you there. Yeah, I think that's, yeah. So granuloma plus lymph node is a complex. I think GON focus is just the granuloma on its own. Does that make sense? Any questions about that? Yeah, cool. So this is closer to what miliary TV looks like. This is still not a great image, and I'm sorry about the quality, but you get like widespread shadowing. And if this was better quality, if you zoomed in, you would see like a rice-esque looking tiny gray particles everywhere. So now that I've told you this is miliary TV, what extra investigation would you probably want to do in this patient? So you could do an echo if you're worried about cardiac involvement. We'll talk about like systemic manifestations of TB in a minute. What else? HIV test, absolutely, really important. Skeletal survey if they've got bone TB, yeah, definitely. One other thing, another important system to check up on. MRI, you could do renal ultrasound. You could do if they had like renal symptoms. You do a lumbar puncture because they can. Yeah, CT less. You do a CT before you did a lumbar puncture anyway. So yeah, that is the correct answer. But if you see miliary TB, you do want to do a lumbar puncture to see if they've got any neurological involvement. All right, fine. And we'll come back to talking about disseminated TB in a minute. So does anyone know like a good acronym for remembering how we treat TB? Yeah, right. So what are the 4 drugs that come with RIPE? Yeah, exactly. Rifampicin, isoniazid, pyrazinamide, and ethambutol. And the great thing about RIPE is you can remember it like this. So the RI that's meant to be 6 months, not 4 months. But the P and E you only do for the first 2 months because they're bacteriostatic, so you're slowing down the infection. I'll change the slides. But yeah, 6 months total treatment for pulmonary tuberculosis. And we went over this on Tuesday if you did the ortho room lecture, but we'll talk about it again. What are the different side effects? So if someone wants to have a go at rifampicin first, what are the main side effects? Red, yeah. Orange secretions. Yeah, you can get like you can get flu-like symptoms, hepatitis. One other important one, probably the most important considering people are on like millions of medication now. Yeah, it's an inducer, and that comes up in exams a lot. Yeah. Also, it can cause like this weird thrombocytopenia, but I think that's through the hepatitis mechanism. Okay, isoniazid. Yeah, peripheral neuropathy. Yeah, it can cause deranged LFTs because most of them can. There's another weird immune one we talked about on Tuesday. Ooh, does it cause prolonged QT? I don't actually know. Let's find out. It can cause like a weird drug like skin reaction, but it's not Stevens-Johnson syndrome.
Yeah.
Yes, it causes drug-induced lupus. So what would you treat a neuropathy with in this case? Pyridoxine, what's the other name for pyridoxine? Yeah, B6. What antibody are we using for drug? Do we test for drug-induced lupus? Antihistone antibodies, exactly. Fine. I'm just checking the isoniazid causing the long QT. Apparently it can. That's niche knowledge, I guess.
I think most antibacterials can actually.
Yeah, I think so. There's like one of the groups causes them specifically, but I can't remember which one.
I think it's the macrolides.
Yeah, I think it is. Oh yeah, Clary. Yeah. Fine. Pyrazinamide side effects. These are like the side effects I love testing you on. Hepatotoxic, yeah. Gout, yes. And by that mechanism, arthralgia. And what is like the main chemical abnormality you get with gout? Like what causes it? Hyperuricemia, exactly. Right, and ethambutol. There's one important thing that you all knew about. Yeah, causes like an optic neuritis. Yeah, retinal toxicity. And what investigations are you going to do for it? Yeah, so you're going to check for color vision at baseline and one other thing. Ishihara is color vision. Yeah, exactly. So you've done color vision, you need to test. Not endoscopy so much, although you might see like some degeneration of endoscopy. Yeah, visual acuity. And you do those at like just before you start ethambutol, and if they're going to be on the drug for longer than 2 months, you have to do it every month past the first 2 months. Fine. And then, like I mentioned how disseminated TB is like a systemic disease, and it can cause all of these weird and wonderful things that you won't see in the UK. So, central nervous system really important. It can cause meningitis, and it can cause focal neurology by causing abscesses. GI can cause like obstruction because it can get granulomas near the ileocecal valve. Can cause like a weird pericarditis. Important things if like people who've lived like in less developed countries for a long time, vertebral collapse and abscesses. So they'll get weird neurology as well. SBA fodder, they love like renal tuberculosis presents with sterile pyuria. Just comes up in SBAs. It's just always renal tuberculosis that it does.
It's more likely to cause a tubulointerstitial nephritis rather than anything else.
Yeah, that's the most common thing, isn't it?
Also, isoniazid is a P450 inhibitor. Just good to keep in the back of your mind.
Yeah. I think all of them but rifampicin are inhibitors, actually.
Yeah, but rifampicin has like a greater effect than all of them. So if you're giving all four, then it's more of an inducer as a package.
Yeah, because rifampicin is just really potent. And then you get weird skin signs. Right, what is the skin sign? Yes, erythema nodosum. And how would you categorize the causes of erythema nodosum? No, the word categorize, rather than just give me the causes. Don't give me the causes. So yeah, there are autoimmune causes, and there are. Yeah, you can use the entire surgical sieve, but we don't need all of it. There's like 2 main groups here. But yeah, using the surgical sieve is always a good idea. Yeah, so you have autoimmune and infective causes. So the infective causes, the most common of which is tuberculosis. Also, group A strep that causes like throat infections can cause a Yersinia. Does anyone know what Yersinia causes? It's a weird thing. It was a bit more common in history than it is now. It's plague. And some viruses can cause it as well. And then autoimmune causes, the most common is probably sarcoid, like inflammatory bowel disease. And then you also have like paraneoplastic effects from different cancers. All right. And does anyone know what like erythema nodosum actually is? Like what what the like pathophysiology is. It's like one of those things that people love. They just love throwing out erythema nodosum, but like nobody actually kind of knows what it is. Yeah, it's subcutaneous flat inflammation. Like the septa between the fat, they get inflamed, and you get like erythema nodosum. Fine. So the last thing we're going to talk about is latent TB and one tiny other thing. So latent TB, what tests can we do specifically? Yeah, so the two big tests for this are like the MON2 test and the interferon gamma release assay. The skin test is a bit older. There's some cutoffs for diagnosis. I put them in like the notes for the slide, but I don't think you need to know them. IGRA is just better and everyone uses it. It's more expensive. And does anyone know how you would treat latent TB? And when you would treat, rather? Treatment is the same pretty much. When would you treat someone who has latent tuberculosis? Yeah, high-risk individuals, if they're immunocompromised, so it's basically prophylaxis. And yes, if a patient wants to be treated for TB, like, kind of hard to argue with that. What examples of immunocompromised people do we treat on a regular basis? Yeah, DMARDs, HIV patients, people on chemo. Yeah, exactly that kind of people. And what is the biggest problem we have with tuberculosis today? Would diabetes fit in within that? That's a good question. I'm not actually sure. Yeah. So it's like a combination of things. It's like the drug resistance due to compliance to treatment. So you're treating people for 6 months, which is a long time. So it's really hard to make sure that they actually comply. So there's crazy rates of resistance. So there's two like main categories of drug resistance. You have multi-drug resistant and extremely drug resistant. I don't think you really need to know these, but it's a good thing to be aware of, because as soon as someone falls into these categories, they're probably going to be you probably need to treat them for like 2 years. If you can't get people to comply to treatment for 6 months, how are you going to get them to comply for 2 years? Nightmare, basically. Also, TB drugs aren't very nice, so and they're going to be put on some stronger agents. You might use things like streptomycin and some older antibiotics that have loads of other side effects as well. So, this is a huge problem, and it's becoming more and more prevalent. So finding and treating tuberculosis early and actually treating it completely is a really important thing. That is my last slide. Does anyone have any questions about tuberculosis? I'm just going to post a feedback form in the chat. Do we need to know what the second line treatment is for TB? So I think having an idea of what kind of other antibiotics you can use isn't really a bad idea. But I don't think they're going to ask you that in an exam, to be perfectly honest.
I don't think it will come up.
Yeah. What's an auramine stain? It's just another stain you can use. You don't need to know it. They won't ask you about it. Zeal-Nielsen is the only stain you really need to know for TB.
Also, just quickly, why the reason why we use IGRA apart from rather than a MAN2 is because you can still use them in people who've had BCG vaccines, and MAN2 will come back positive regardless.
Oh, yeah.
Whereas in IGRA, even if they've had a BCG, it can still test for latent TB.
Do you stop tuberculosis treatment early if they get side effects? Unless they're really bad, probably not. Tuberculosis is probably worse than any of the side effects.
There's specialist TB nurse clinics that deal with this, specifically drugs and side effects, just because it's so complicated. So I doubt you'd need to know when to stop TB medication.
Yeah. there's a link. Just say just put the session name as Season 1, Episode 1, S1E1. Or if you have any specific feedback, just drop us a message. Arnav's volunteering from next week, but we'll try and do another thing sometime soon.
Let me know if you want it sort of more quick fire like Anusha's done, or whether you want it sort of longer like I did.
Yeah.
I don't mind doing either.
Tell us like what kind of stuff you want more of.
Like, do you want spot diagnoses, quick cases, that sort of stuff, or something from the beginning to end sort of thing?
Or a mix of both.
Yeah, or a mix.
Well, no problem. Mix.
Cool.
Yeah, everyone loves a mix of everything. Fine. Right, I have another call to get to. I'm going to go.
Cool.
Have a good day.